pleasant morning to each and every one of you. This video is all about assisting in thoracentesis and lumbar puncture, presented to you by Group C5. First, let's talk about that assisting in thoracentesis. Objectives. 1. Define the terms related to assisting in thoracentesis. 2. Discuss the importance of thoracentesis. 3. Examine the guidelines in assisting in thoracentesis. 4. Discuss the indications and contraindications of thoracentesis. 5. Explain the complications of thoracentesis. 6. Identify the different sites and position in thoracentesis. 7. Compare ultrasound-guided and non-ultrasound-guided thoracentesis. Number 8. Explain the principle involved in assisting in thoracentesis. And number 9. List the nursing responsibilities before, during, and after thoracentesis. And lastly, number 10. Document client responses and outcomes after thoracentesis.
Good day, I'm Ms. Tony Capilitan. Now I'll be discussing course learning outcome number 1, which is to define the terms related to assisting in thoracentesis. So the first term is thoracentesis. Thoracentesis is performed for diagnostic or therapeutic reasons. The purpose of this procedure includes removal of fluid and very rarely air from the pleural cavity, aspiration of pleural fluid for analysis, pleural biopsy, and the instillation of medication into the pleural space. The second term is aspiration. Aspiration is the inhalation of foreign material into the lungs. It is a serious complication that can cause pneumonia and result in tachycardia, dyspnea, central cyanosis, hypertension, hypotension, and potentially death. It can occur when the protective airway reflexes are decreased or absent due to a variety of factors. It may occur if the patient cannot adequately coordinate protective glottic, laryngeal, and cough reflexes. This hazard is increased if the patient has a distended abdomen, is supine, has the upper extremities immobilized in any manner, receives local anesthetic agents to the oropharyngeal or laryngeal area for diagnostic procedures, has been sedated, or has had long-term intubation. The third term is centesis. Centesis comes from the Greek root kent, which means to prick or jab, and comes from the term centesis, which means surgical puncture. Centesis is the surgical puncturing of a part of the body with a hollow needle in order to extract fluid. It is usually for diagnostic purposes. So the fourth term is the pleural cavity. The lungs are contained within the thoracic cavity, and each lung is surrounded by a separate pleural cavity. Each pleural cavity is lined with a serous membrane called the pleura, which consists of a parietal and a visceral part. The parietal pleura lines the walls of the thorax, diaphragm, and the mediastinum. The visceral pleura covers the surface of the lungs. The parietal pleura is continuous with the visceral pleura. The pleural cavity between the parietal and the visceral pleura is filled with a small volume of pleural fluid produced by the pleural membranes. The pleural fluid performs two functions. First, it acts as a lubricant, allowing the visceral and parietal pleurae to slide past each other as the lungs and thorax change shape during respiration. And second, it helps hold the pleural membranes together.
The importance of thoracentesis. Thoracentesis may relieve pressure from the fluid in the lungs, treating symptoms such as chest pain and shortness of breath. Also, its evaluation of the fluid removed may determine the underlying cause of excess fluid in the pleural space.
Hello everyone, I am Suzette Marie Perez, and today I will be discussing CLO number 3, which is examining the guidelines in assisting thoracentesis. Our first guideline Our first guideline would be establish patient on continuous cardiac monitoring and pulse oximetry. This is done so that there will be continuous monitoring of the patient all throughout the procedure. Second, oxygen therapy should be administered during the procedure. Unless contraindicated, this is to offset hypoxemia produced by changes in ventilation-perfusion relationships as fluid is removed and to facilitate reabsorption of pleural air if pneumothorax complicates the procedure. Third, position the patient. For trauma patient, place them in head-up supine position. This is done to prevent more trauma, while all other patients should be placed in 45 degrees sitting position with the arm that is at the same side as the collection placed over the head. This position facilitates access to the posterior axillary space, which is the most dependent part of the thorax. Fourth is palpate landmarks. The fourth or the fifth intercostal space just anterior to the mid-axillary line or the second intercostal space at the upper border of the third rib in the mid-clavicular line. Fifth, antiseptically prepare the area. Asepsis is required if a chest drain is inserted. This is to prevent the site from getting infected. Sixth, ensure that the local anesthetic is infiltrated from subcutaneous tissue down to pleura in order for the anesthesia to be effective. Seventh, intention pneumothorax. Often you will hear a pop or feel a change in resistance. Eighth, secure the cannula with a tape and secure a waterproof transparent dressing so that the cannula will stay in place or in the same area all throughout the procedure. Ninth, drain until no further drainage to a maximum of 2.5 liters. 10. Do not remove the aspiration device until a decision is made that the patient will not require further drainage.
Hello everyone, I am Zarina May Laurente and I will be discussing CLO number 4, the indications and contraindications of thoracentesis. Indications of thoracentesis. Thoracentesis should be performed diagnostically whenever the excessive fluid is of a known etiology. It can also be performed therapeutically when the volume of fluid is causing significant clinical symptoms. It is also indicated for the symptomatic treatment of large pleural effusions or for treatment of empyema. Empyema is a collection of pus in the pleural cavity. It is also indicated for pleural effusions of any size that require diagnostic analysis. There are no absolute contraindications for thoracentesis. Relative contraindications include the following: uncorrected bleeding diastasis, and chest wall cellulitis at the site of puncture. Still, this is Zarina Laurente to discuss CLO number 5, the complications of thoracentesis. First is pneumothorax. This may occur if the operator inserts the needle into the lung. Another way this could conceivably occur may be if the stiff plastic catheter is inserted in the middle of the thorax rather than over the diaphragm, forcing the lung to re-expand around the catheter. Next is bleeding. Bleeding is a risk complication for thoracentesis in a way that when the person who has undergone thoracentesis is not yet fully recovered, it will cause bleeding in the injection site. Third is infection. If the needle or the tube is placed in the wrong site, there is a tendency that the fluid from the effusion will reach the lungs and infect it, thus causing multiple complications. And lastly, the liver or spleen injury, which occurs very rare. Liver or spleen injury also has to deal with improper site injection. Laceration of diaphragm, liver or spleen may happen if the care provider punctures in a wrong site. So one must be careful in performing such procedure since these organs are not far from the lungs and can be easily affected.
Good day everyone, I am Stephen Plaza and I will be reporting about the different sites and positions in thoracentesis. The thoracentesis site should be in the mid-scapular or posterior axillary line, which is 5 to 10 centimeters lateral to spine, and 1 to 2 intercostal spaces below the highest level of the effusion. The picture shows the insertion site of the thoracentesis. And now, in order to minimize potential injury of the diaphragm, the lowest recommended level for thoracentesis is between the 8th and 9th ribs. There are two types of thoracentesis approach. The first one is the posterior thoracentesis approach. In this, the patient should be sitting forward over a support. The location of the needle placement is best determined by using ultrasound, and a typical puncture point is shown in the illustration. So for the posterior thoracentesis approach, it has advantages and disadvantages. For advantages, sitting in the position helps spread out the spaces between the ribs, making it easier for the doctor to insert the needle into the pleural space. Patients who are alert and cooperative are most comfortable in a seated position. And for its disadvantage, it is not suitable for unstable patients and those who are unable to sit up. Another type of thoracentesis approach is the lateral thoracentesis approach. The patient should be lying supine with the arm extended and the head of the bed elevated. The location of needle placement is best determined by using ultrasound. A typical puncture point is shown in this illustration. So for the lateral thoracentesis approach, its advantage is that it is suitable for patients who are unable to sit up, while for its disadvantages, it is less comfortable for patients who are alert and able to sit up. Supine thoracentesis can be very difficult. The effusion gravitates down to the posterior surface, limiting the space to maneuver the needle syringe assembly. And this approach is technically demanding and time consuming.
Hello, I will now be tackling about the advantages and disadvantages of a non-ultrasound guided and ultrasound guided thoracentesis. Firstly, we will tackle about the ultrasound guided thoracentesis. Its advantages are: it is useful in differentiating pleural fluid from lung atelectasis, infiltrate, or an elevated hemidiaphragm identified on chest radiograph in the acutely ill patient. Also, it is useful for the rapid visualization of the parietal and visceral pleural surfaces, evaluation for pneumothorax, and to some extent, the evaluation of the lung parenchyma. It also reduces the rate of pneumothorax and tube thoracostomy in oncological patients, thus improving safety. And lastly, there is no need for surgical incision. Now, its disadvantages are: it may have complications, and these complications may include pneumothorax, or a parietal collapse of the lung caused by air entering the pleural space through the needle or rarely by the needle puncturing the lung, allowing air to flow into the pleural space. Pulmonary edema, which may occur if a large amount of fluid is removed too rapidly. And it may also induce infection and bleeding, which may also lead to breathing difficulties. Thoracentesis may not be performed on patients who have an uncorrectable bleeding disorder, which may lead to further complication of the condition of the patient. Also, it is also known to be expensive. And lastly, it requires the availability of an expert or skilled practitioner to perform. It cannot be done by any nurse or physician that is present at the moment. It has to be done by an expert or a skilled practitioner for legal reasons. Next, we have the non-ultrasound guided thoracentesis. Its advantage is it is more affordable. For its disadvantages, it is found to have more complication rate or a higher complication rate compared to ultrasound guided thoracentesis. It is also time consuming, meaning it consumes more time during the procedure, thus making the patient or client more susceptible to infections and further complications. It also may require surgical incision, thus creating high chances of infection. And lastly, it exposes the client more to infections and complications during the procedure.
Hello once again, I am Zarina Lorente to explain to you CLO number 8, the principles involved in assisting in thoracentesis. First, we have the anatomy and physiology. In assisting in thoracentesis, the nurse must know the appropriate puncture point in order to avoid any unnecessary complications caused by puncture in an incorrect site. Next is microbiology. Microorganisms may cause infections that could complicate or worsen the patient's condition. The nurse must ensure that sterility of equipment and materials used in thoracentesis is maintained. Psychology. Before conducting the procedure, the nurse must explain the procedure and the purpose thereof to the client to alleviate anxiety. Physics. This refers to the use of physics in conducting thoracentesis. For example, using force in order to make a concise puncture. Safety and security. Safety of the client should be given utmost importance to avoid injuries or accidents. This is best exemplified in the proper execution of the procedure and proper handling of the syringe. And lastly, we have the sociology. Building rapport with the client prior to the procedure is important in order to gain his or her trust.